What would you say to health practitioners?
I think it's just it starts with validation and just listening and a welcoming smile, not Millie. And then they've run down and I'm following them. I don't know what door they've gone down. In the waiting room, just having some colour and maybe some greenery, some plants, the classic fish tank.
Welcome everyone to this episode of Endo Untangled, where we pull apart all of the different threads associated with endometriosis and pelvic pain. I'm Dr. Alicia Macro. I am a GP who has a special interest in pelvic pain and endometriosis, and I'm joined, as always, by my colleague, exercise physiologist Cherie Noble. Cherie, g'day.
Alicia, hello. What a awesome week that we are having with this episode.
Cherie. So today we are very lucky to be joined by Dr. Millie Mardon, a researcher, educator, and someone who's lived with endometriosis since her teens. Diagnosed as a teen, Millie brings both personal insight and academic clarity to the way she thinks about pelvic pain. She's trained under Professor Lorimer Moseley, a leader in modern pain science, and is now a postdoctoral fellow at the NICM Health Research Institute and UniSA.
I'm an adjunct, so it counts.
Okay. Her research focuses on how people understand pain, what clinicians can do better, and how self-management, education and validation can shift outcomes. Millie Mardon, welcome to the podcast.
Thanks so much for having me. This is very cool and very fancy.
We have been very, very, very looking forward to having you on and hearing all about your thoughts on this topic. So we are going to delve into the science of pelvic pain today, and particularly the neuroscience of pain. But before we get into that, I would love first to hear a little bit more about you because, as we've mentioned, my understanding is that you have endo yourself and you've been through your own endo journey starting in the country,
yes,
regional South Australia. I'd love to hear about, before we talk about all your amazing work that you've done in pelvic pain science, where did this all start for you?
Yeah, so I guess it all started with my first period, which I think is the same for a lot of women and people assigned female at birth out there. So yeah, ever since my mum always says you had one normal period and that was your first one. And it was, I think, the day before I went off to year 7 camp.
It's always the camp, isn't it? It always coincides with the first camp.
Yeah. And ever since then, I had horrific periods. They were super frequent. I think they were about every 2 weeks, super heavy. I was off school a few days every couple of weeks. Nothing was really helping manage that. Alongside the flooding and the heavy periods was the really bad period pain, which gradually over time turned into more consistent pelvic pain. I had really bad bloating, nausea, fatigue. I was just knocked out in bed in the fetal position. And this was all when I was about 12 years old. So, yeah, in year 7.
That's a lot for a 12-year-old.
It's heartbreaking, isn't it?
It is. And so I think luckily the doctors were quite good where I'm from. The paediatricians there got referrals to come to the Women's and Children's here in Adelaide. And luckily I have very supportive parents and family. So they were able to bring me to Adelaide in the 3-hour car trip to get me there to an appointment and bring me the 3 hours back in a day and see some specialists. And in between ages of 12 to 14, tried different pills, got potentially accused that I was lying about not being sexually active and I could be pregnant, and got made to take pregnancy tests it was a whole thing. And at age 14, I had a laparoscopy at the Women's and Kids, and that's when I was diagnosed with endometriosis. Had no idea what that was. That was day surgery. I came down with I can vividly remember, I woke up, from day surgery saying, oh yeah, found endometriosis. What is that? No one's told me about this at all. And then day surgery, so spent the night in a hotel room with my mum and my nana who came down as well. And then the day after I had to make the 3-hour car trip back home with 3 fresh incisions with the pillow stuffed in between the seatbelt, just on the bumpy highway, back. And I did not know what I was in for at all. And unfortunately, that surgery didn't really do anything. I did get the Mirena put in at the same time, but that didn't really do too much then. And so then it was probably from age 14 to 17, I just kept trying different pills to try and just stop the bleeding, calm everything down. Nothing really worked. And so at age 17, I went and I ended up having a second surgery. And I think that was a much nicer experience. And at the same time, I was seeing a women's health GP who worked alongside the gynae surgeon, which was great. I started delving into food-related stuff and gut-related stuff. So I went and saw a dietitian. I think that was really helpful. But I think the big kicker, I felt like I had to drive a lot of my own care. I heard about a thing called pelvic health physio, and I thought that might be really helpful for me to manage some of my pain stuff. But I had to be the one to go and say, do you think this would be good? And she's like, yeah, I've got contacts. That'd be great. I kind of wish that got suggested a little bit earlier and I didn't have to do that advocating for me, but I guess I'm lucky I did. But yeah, then since 17, 18, starting uni, moving to Adelaide, I've actually had a relatively good experience. And I think that's through the combination of I had a decent surgery at the right time for me. The Mirena, I've loved it. It's been really helpful for me to, I don't have to worry about a period, and that's the best thing ever. Endo, like other medications to help with the headaches and getting me to sleep. That was really good, but I'm not on that anymore, so that's nice. Physio was amazing. Looking at food and what potential triggers could be causing any of that sort of pain, that was really helpful. And yeah, just I guess keeping in touch with friends and family and trying to get out there as much as possible, maintaining exercise as well. I was a very sporty kid, and then having pain so bad that it takes you away from participating in your sport, that's life change. Like that's a thing that I think of was a big life impact for me. And I remember, some doctors saying just go for a walk, and I'm like, I would if I could, but I didn't know why they were suggesting go for a walk. Like, is this a fat joke? You're telling me like I'm putting on weight and I just need to go for a walk? Like, I would if I could. That's a whole other thing that I'm sure we can get into.
Yeah.
But I think it's just the combination and finding out a really good support system, a great GP, really good allied health professionals, my gynecologist when I need to see her. I know I can see her, which thankfully I haven't really had to. But I think having that really good support system was a key factor. And I wasn't just putting all my eggs in one basket, in one medication or one surgery or one intervention. I was able to really look at that holistically and look at, what are my triggers for pelvic pain or what things can help me best as well. So yeah, I'm very fortunate that pretty much for the last 10 years, I'd say I'm pain-free and I've recovered, and it doesn't really play any role in my life except in the research space now. So,
What a story. And just listening to you speak, Millie, I think the thing that stands out for me is you embracing some of the concepts that we actually work with and use. As a young person, navigating this yourself is such a credit to you. And we talk a lot about wayfinding, which is what you've done, navigating, well, this didn't work, but I tried this and I tried that. And we also talk a lot about holding concepts lightly, and you mentioned that you had a Mirena and then that didn't work, but then you do have one, so it didn't work at that time. So hopefully our listeners are kind of inspired by your journey, because it sounds like you went through it. Yeah.
And I feel like my mum would probably have different recollections than me. I feel like if we get into the brain science stuff, if to be 100% honest, I don't really remember much of that time, and that's probably because the pain and the brain doesn't really want to remember nasty situations like that. I reckon, like if you asked me what medications have you tried, then I would have no idea.
Oh, really? That's interesting.
I would have no idea.
Yeah.
So I think my mum would probably have a different recollection.
Yeah. I was wondering when you were telling your story, I mean, it surprises me in a good way that you were country kid who got picked up and referred and actually formally diagnosed by 14. That's not a story that I hear often. And I was thinking, I wonder if you were just lucky, or perhaps there was mum or someone similar who was in there advocating for you. Like, do you remember much about that, or have you talked to your family much about what that was like?
I think it's probably a combination of different things. I think acknowledging that, we lived in the country, but also in a very privileged position where my mum was able to take a day off work and bring me to Adelaide. We had the means to do that. And, we come off, we're an educated family and we sort of understood that. And my younger brothers had health problems. So the health system was not new to our family at all. So I think that probably helps. And definitely mum being a good advocate for her sick daughter was definitely a big role in that. And it just raises the question. So it probably took 2 years from symptoms to diagnosis. And I wonder if that, like a lot of people out there, it takes 10 years plus. And so I wonder if that happened to me, I probably would be in I'd be in a completely different trajectory of life.
Yes.
Might not have gone to uni and that sort of stuff. So it does make you reflect on, I guess, not just what's going on inside of my pelvis and that kind of stuff, or down to what stage of endo I had. I don't even know what stage of endo I had. I think they said, oh yeah, it was bad, but not the worst I've seen, but your tubes look good. Like, that's what I remember. I don't remember, and that doesn't bother me really. But it was very much about my support system and having the doctors that were like, no, you need to go to Adelaide and get a referral to go see a specialist, and having the family there to help you get you there.
We were talking a bit off air about some research that you've been involved in through the PEP Talk. So that's the school education program that's, I think, run through the Pelvic Pain Foundation of Australia. The differences in the research that have been collected from these high school kids and perhaps senior primary school kids around how much school is missed, how much sport is missed, all sorts of things. And there are stark differences between country and city kids in terms of how badly they can be affected, with country kids usually worse off. And so, although I would say, listening to your story and having been a GP who's come through rural general practice through my training, so I think it probably surprises people who live in the city how good country doctors often are.
Yeah.
But then there's also, there can be a lack of access as well. So, listening to your story, you think, well done, Mum, because you're right. Like, give you 10 years in that lost space without the right help. Yeah, you might not be sitting here having this conversation. You might be
on a different path. Yeah, I'm pretty confident that would be the case.
Sliding doors.
Yeah.
Okay, so thinking about that little Millie, teenage Millie, who's going through all of this, and with the pillow between you and the seatbelt in the car to and from Adelaide and Port Augusta, and now to being a PhD researcher in pelvic pain and pain neuroscience. Can you tell us about how you got from being that kid to being where we are now?
I was always a bit of a nerd.
Well, you're with the right company here.
Definitely always a nerd. Loved bio and chem in school. For some reason I preferred chem over bio, but I always did better in bio than chem. And I did medical science as my undergrad because I was really, I didn't have one particular interest. I liked the degree because I could really choose what I was interested in. So I did a nursing subject. I did a pharmacy subject. I did evolution. We got to play with Lego. Like, that was kind of wild.
You got to play with Lego for evolution?
Yeah, like we made little Lego animals and like changed them one by one to show you evolution. This is part of a uni degree that, yes, we did pay thousands to do that. We got to play Lego. But I really, in my last year of the degree, I found myself really enjoying wet lab work. So gal with the goggles, white lab coat with a pipette in hand. I really enjoyed it.
Is that my worst nightmare? Sorry to interrupt.
You'll soon realise that it became my worst nightmare too. So I did my honours, and that was in pancreatic cancer tissue biomarkers. Like, honours was fine, but I just realised I'm not that type of person that can sit in a lab by themselves for 8-9 hours a day staring at cells wiggle around. I just realised it wasn't for me, and I needed to do work with or research with actual alive human beings that could like talk back to me. And so at the end of my honours, I knew I was still really interested in research and generating new knowledge, and so I went to a little seminar that they had at uni, and that's where I came to know about more of the allied health research space, where the physios and the ex-phys people are. And to me before then, it was very separate. So we were like the nerdy kids now, white lab coats, and they were all walking around in like their Lululemon with their Kathmandu puffer jackets. And it's very distinct at the uni. It's like there's a segregation. You can tell who's who.
There actually is.
You can still
tell.
So
yes. I still wear a Kathmandu jacket. I took it off.
I've graduated to my Kathmandu jacket.
We don't give it to everyone, so
there you go. Phew, I passed. And so I just went, that is me. I need to do research with actual alive human beings. And so I started doing a little bit more research about what's at the uni, and I came across a group that researches chronic pain and pain in general. And I went, that actually sounds super interesting. I didn't really know much about it to begin with. But through my own experience and other family members' experience of chronic pain, it really piqued my interest. And so I made a meeting with someone who put me in touch with this guy called Lorimer, and I went and had a meeting with him. I was like, yeah, like I'm interested. And that's sort of where it all took off. And I saw that someone had published a thesis in pelvic pain. And so I went, oh yeah, I think that's where I need to be. And that someone ended up turning into my principal supervisor. And just, I guess all the stars aligned pretty much.
So you've dropped the name Lorimer. So it actually surprises me that there are, when I talk to patients and even sometimes other health professionals about pain science and ask them if they're familiar with Lorimer Moseley's work, and there's probably some people listening to this who might not be familiar with his work, but we're talking about an Adelaide-based physiotherapist who, well, my impression, and I'd love to hear your impression, but he's someone who really drove a lot of change in the way that we think about pain.
Yeah.
Globally.
Yeah.
Would that be true? Can you tell me a bit about what you know about Lorimer?
Yeah, so probably around 25-ish years ago now, Lorimer and his good friend Dave Butler really pioneered this new way of thinking about chronic pain and really acknowledging the neuroscience behind it, but not only being able to understand the neuroscience and the biology, but able to put it in a way that's really digestible and understandable for not only clinicians, but patients as well. And it really encapsulated, I guess, rewired people's thinking or reconceptualizing people's beliefs about pain from being purely biomedical and it's something in the body to do with your tissues, that it is much more complex than that, and a lot more, I guess, creative, and involves so much more than just painful body parts. And that really drove this new way of thinking about pain, about learning about pain, talking about pain, and managing pain as well. So they developed a book called Explain Pain, and that was really the first ever pain education resource in the world. And yeah, like I said, I think it was the first way that made it really digestible, and they linked it to learning, which I think is really cool as well. So it's all embedded with educational theories as well. And yeah, making links between how we learn knowledge, but also then, the science of pain as well, which I think is really cool way to go about it.
I'm thinking about the cover artwork of that Explain Pain book, and we can certainly link to it in our show notes, where there is a person with a toe that's stepping on a nail, I think.
Yes.
And then it's almost like this concept of, you step on something sharp, you get acute tissue damage in that particular body part. It lights up the network straight to the brain, and the brain recognises that tissue damage as pain, which is, thinking back 20 years ago when I was in medical school, that's pretty much how we were taught to conceptualise pain. And that is one way that pain can present itself, but that's only one one part of the way that pain presents itself. And I think the classic analogy or example that's given to perhaps describe that there can be more going on there is the idea of phantom limb pain, for example. So, someone can have pain in a toe that doesn't exist anymore, which doesn't mean that pain's not real, but it's not indicating tissue damage in a toe that doesn't exist. Yeah. So you've come from being this kid in the car to and from Adelaide to someone working in this pain research field. I guess to build on that, if we're thinking about someone who might be listening to this podcast who is having daily pain, and we know that there will be people listening to it who are having pain every day. I know because I meet them every day too. What do you think? What does it sort of mean? What might it mean for them to sort of suggest that pain doesn't always mean damage?
Yeah, so I think in the endo space, a classic example is the amount of pain that you experience doesn't correlate to your stage or severity of endo. I know a lot of people that have stage 4 endo don't actually have pain at all. They might come with infertility problems and they can't get pregnant. Investigate that further. Wow, you've got endo. And so that's just a classic example of how pain is so much more complex than that. And I think we can all draw on, personal experiences where, when you get a paper cut on your finger and it's always at the worst time when you're rushing and you're stressed and maybe uni assignments due and that paper cut bloody hurts and it's the only thing you can think about and it's so distracting. If you get a paper cut like any other time, you might just be able to, move on, get on with your day. But in that stressful situation when you get that paper cut, it's like, oh my God, it's the worst thing ever. And it's all I can think about. Now my finger's throbbing. And how am I going to get my assignment done? So just recognizing that lots of different factors can actually have a role in people's pain experience. And that can change from, can change day by day. And every time someone experiences pain, different factors are potentially playing a role. Obviously, tissue damage or tissue pathology like an endometriosis lesion can have a role. We're really speaking to the biopsychosocial model where biology, psychology and social well-being is all having a role in your experience of pain. I think sometimes people are really quick to dismiss the bio part, but the bio is still there. It's just saying it's not all of your puzzle. It's one piece. It might be an important piece. It might not necessarily be that important for others. But yeah, just recognizing that pain is a lot more complex and there's lots of other things going into that as to why you're experiencing pain.
So from your research and from that pain education perspective, what would you say to clinicians and patients around, you talked about the biopsychosocial model and how we shouldn't dismiss the bio, but there are psychosocial factors. What's your biggest takeaway or, what concepts would you love people to kind of know about?
Yes, I think tying, the biopsychosocial model to the...
Which I love, by the way. Yeah, and everyone who knows me will be just rolling their eyes because I talk about it all the time and they're just like, oh, here we go again.
But tying that with neuroscience as well. So part of my research was I interviewed 20 people who had a lived experience of pelvic pain and had learnt about pain in some regard. And we wanted to know what was really important for them to learn. And so through that, 4 key themes stood out being very prominent. And so the first one was really learning about the role of the brain and the nervous system in pain. That's a proven fact. The experience of pain involves the nervous system and the brain, like you're saying, Alicia. We experience something goes on, it triggers a receptor, messages get sent from our nervous system to our spinal cord up to our brain. Our brain goes, what's going on here? Does our body need protecting? Oh, I think it does. Shoots the messages back down and we experience pain. So that is a fact. And so learning though, every time that happens, our nervous system and our brain is actually becoming more sensitive and receptive to those messages. And sometimes it can become so sensitive that it doesn't even need anything like a cut or inflammation or tissue damage, as we'd say, to even fire. It might be something else. It might be another threatening experience like stress, poor sleep. Perhaps you ate something that doesn't really agree with you. They can all be seen as dangerous and potentially threatening, even though they're not going to kill us, but our brain, our nervous system have almost learnt in a way that this ain't good. We got to protect you here. Like, we've been here before. This is dangerous territory. We'll give you some pain to try and protect and elicit a response from you to do something about it. Learning that our brain, our nervous system it does have a role in pain, and then that can become really sensitive over time. And so what that might look like in clinic is someone might have someone might have had really bad period pain. That period pain might only be, the 2 days before their period and the first 2 days of their period. But now actually, we're not managing that very well. And now that's becoming, you're getting pain, the whole period. And now it's turning into 2 weeks of the cycle. And now, it's not really period pain anymore. I'd say it's pelvic pain and it's everywhere. And now our bowels are starting to get really sore and it hurts to wee. And now we've got leg pain. Oh, that's a bit weird. And we've got pain on our back and we're really tired. We're really irritable. We don't want to do anything. They're all signs our nervous system are becoming more sensitive, and our body's trying to protect us and go, yeah, we just need to chill out a little bit. So they're all very much signs that our brain and our nervous system are becoming sensitive. So learning about that was actually really important for people because, it validated their experience as being real. There's biological processes going on in our body. Yes, they might not necessarily show up in surgery or on an ultrasound scan, but I promise you they're happening. And so being able to validate that was really important for people because we obviously interviewed people with pelvic pain. And so some people didn't have endo, some people had bladder pain or vulva pain. And so nothing comes up in a scan or ultrasound, but learning that really validated their experiences. And it also gave them the ability to communicate their pain. So it's much easier to talk about your brain and your nervous system rather than, well, I have pain with sex or, it hurts when I poop. But being able to talk about the brain and the nervous system was much more digestible when talking about their experiences with friends and family. So that was really helpful. And then learning about the correlation between pain and tissue damage as well. Like, there isn't a strong correlation between the amount of pain someone has and the amount of tissue pathology that's going on in their pelvis. So being able to learn that was really important. So if someone was to have a flare, it didn't necessarily mean any disease was worsening. It might have been something else, like the third concept. It might be how people think, feel, and see the world and how that can have a role. So that's really speaking to the psychosocial factors. So being able to acknowledge stress, poor sleep, if you have another chronic condition at the same time, like how all of those factors can play a role, but being able to then identify them, we can put in some nice management strategies to actually get on top of that and potentially calm things down. So I know for me with work, if it's a really stressful time and I'm not feeling great and you potentially have a little bit of a flare up. So being able to, I need to take it easy tonight, do some stress management techniques, which is, might have a nice bath and do some reading or do some colouring, just, take some time for me. That can be really helpful. So being able to identify those other types of factors, and that gives back that sense of control as well.
Yes, we talk about scaffolding quite a bit. Yep. So just being able to have that scaffolding, and then also the biopsychosocial stuff that you were talking about around the way you think, feel and see your pain. Like I can imagine the pain experience is quite different if you're navigating it on your own without much support compared to having someone who's, got your back there, whether that's a GP or an EP or a mum or dad or whoever it is, partner who's in there may also change your experience of pain.
Yeah, absolutely. If you don't have a supportive partner, that's not going to be a fabulous environment to thrive in and heal and recover. So all of that totally has a role, and advocating for yourself in a medical system that isn't well set up to manage these chronic conditions like pelvic pain, that's so tiring. Like, that takes it out of you. I know if I have a doctor's appointment, I'm that person, like 5 hours appointment, I'm not doing anything. I gear myself up for it. So if you're doing that by yourself without any other support, and then you've got to come home, then you've got to do your washing, and then you've got to cook dinner and do all of that, that's exhausting.
And just by what you were saying, like that's obviously then influencing how you're experiencing your pain.
Yeah, absolutely. That can drive up stress there.
So even when you're trying to get help, it can sometimes not hinder, but exacerbate the symptoms.
And even the environments, some hospital environments are super clinical, and I don't know, I'm I'm a fainter. I hate blood. I hate needles. So even like walking to hospital, the smell of the anaesthetic.
Yeah.
I don't want to think about it. Like I'm really bad, and I think it's because I've probably had some not great experiences in it. That all has a role in your environment. It's seen as threatening, and you've had not nice experiences. So
I think some of our patients can attest to that as well. I mean, they've been through the medical system, and had some of these experiences, which then, you know, it is really affecting their experience ongoing.
Yeah, and now I've got a lovely GP, and I know I go to her and I'm safe, and I know I'm going to be listened to, and she's, you know, going to help as much as I can. We're going to get things on track if needed. So forming those relationships and those environments, I think they're very underrated, but they play such an important role in managing.
So just on that, what would you say to health practitioners?
I think it's just like, it starts with validation and just listening and a welcoming smile, not Millie. And then like they've run down and I'm following them. I don't know what door they've gone down. In the waiting room, just having some colour and maybe some greenery, some plants, the classic fish tank.
You have to come to my practice. You haven't been.
I should. Yeah. I should. That's like a fish tank's always a good distraction.
Oh, we don't actually have a fish tank. What have we got? We've got a lot of stuff going on.
It looks like a
It's
home.
like a living room.
It's like a living room.
Yeah. A comfy chair. Like
there's even a couch.
There's a couch.
There's
there's plants.
There's
a bunny lamp, which is new, which I bought in the middle of the night one night when I couldn't sleep. So I'll post a picture of that perhaps. Oh, it's so cute. Yeah. There's cute books. There's no scary posters. So this is a good conversation to have to other health practitioners who are listening, because sometimes you don't think about your environment outside your consulting room, even inside your consulting room. Do you need 50 million scary posters on the wall? Like,
I don't need 20 brochures about cancer sitting there in the wall.
Could it be gonorrhea? You know, could you have a melanoma? You know, like it's
there's so
scary.
much that's coming in, and like you know, this is where I get, you know, think about things as well. Is that not all this stuff is conscious, is it? Like we're taking in our environment, and you know, some of us aren't really processing it, but some of us are taking in all of that information as well, which is overloading our system.
Yeah,
absolutely. And as a practice owner, let me tell you, it takes dedication to keep that junk off your walls and off your bathroom and off your surfaces, because I tell you what, everyone who comes to visit you, I've got a poster to put on the wall. Here's this thing, or here's 50 pamphlets that you can think. This is something you can stick in the behind the toilet door. It's like, okay, no. It's just no. And I say to people, it's not personal, but if you notice, there's none of that stuff in here.
Yeah.
Thank you, but but no,
your environment matters,
and it's like it's like trying to push back the tide sometimes. So we all need to be a little bit more thoughtful about how we're managing things and what are our sort of non-verbal signals to those that we're looking after.
Absolutely,
yeah.
Anyway, so that's about three of your themes so far,
and the last one was just knowing that your pain can change. That might not necessarily mean you're going to be pain-free tomorrow, but over time, you know, if you find your right management strategies, sticking at them, your pain can change and improve over time. It is a slow process, unfortunately, with chronic pain. Like, you know, the way we get there, the way I know for me as well, the way I got there, that, you know, was 2 years, you know, longer than that really, 5+ years it took for me when I was in that state. So it's going to take time for that to actually change and improve, but I promise you it does. And I wouldn't be sitting here preaching that if it wasn't true. And people do see positive outcomes. Yes, it might change as in you can manage it a little bit better. You feel more equipped to manage flares if you're out of the shops and something happens. But, you know, it can change and it can improve as well, that's really powerful and hopeful for people as well. It's not all doom and gloom.
So important and so lovely to hear those like your story in particular around, you've been through it and you have found some tools and got some support and you've managed to come out the other side. Not completely, it's still there, but it's super important. So when you did this study with the participants and they were interviewed, how did it work? Were they given the same pain education, or it was people who'd gotten better and reflecting on what had helped them?
Yeah, so they hadn't had anything in particular. We just sort of vetted it over the phone to be like, how did you engage in this, to learn a bit more, and because at that time, or even still, I was to say even still now, there's not really that much information out there in terms of pelvic pain science education, nothing specific to the pelvis. So we knew going into this, it wasn't like we could go to something in particular and just grab people. And we wanted to just see what's sort of out there. And we did ask these 20 participants, and the most common answer, so 19 out of the 20 people taught themselves. So they just learned through books, through websites, social media. I think they often said, doctor mentioned something about the nervous system, so they went and did further reading themselves. Under that was healthcare professionals, but a lot of it was self-directed learning, and just because they had a real interest in that. I think that speaks the volume of how much this information currently, we're slowly getting there. The tide's slowly turning, but, a few years ago when we did this study, there wasn't really much out there targeted towards the pelvis. Lots of the resources out there, which is a big reason why I wanted to get into this space, is that it's mainly focused on research in musculoskeletal pain conditions. So thinking of back pain, we're thinking of knee pain. And lots of that is, related. It's quite blokey. Like let's be honest, lots of those resources, they talk about footy injuries and hurting your hamstring. I'm like, sorry, that ain't applied to the 12-year-old who's had period pain, for God knows how long.
Yeah.
Though that nuance in the education is really important. And I think reading these resources, I was going, this is so applicable to people with pelvic pain, but it's not in the appropriate language. And we need those examples to really hit home, because me at 14 reading some of these resources, I would have gone, well, that doesn't apply, go away. So actually putting it into words and language that are applicable for people with pelvic pain, super important, and hence why I wanted to get into this space.
Well, you might be proud, Millie, that Cherie and I have run some groups together, and we will be running some more with some of our patients who have pelvic pain. And we used to run a 2-part workshop. And for the early workshops, by the end of the second session, we actually pulled out your 4 points.
Oh, cool.
I've got pictures of this.
We did.
And we wrote them out, and we together reflected on those as a group. There would have been about 10 of us in the group together, including you and I, and kind of drew all over them and put our own thoughts and about, having done some formal, essentially pelvic pain science education, and then coming back to your points. And it was so lovely. It was so lovely and hopeful, wasn't it?
It was, yeah.
And the people who participated in those, I still see, many of them are much better. So nice to be able to incorporate some of our, science and research into clinical work. So it does happen. I wonder if you wonder that if you're
that's actually so nice. Yeah. I'm sitting here going, we should need to write a research grant.
Yeah.
And test this out. We'll talk afterwards.
But I think nice. One of and it was what you said as well. And I'm like, I've heard that before. Oh, we use that. That your pain can change.
Yes.
Slowly.
Yeah. And all those concepts, that was the language that the participants use. So that's really important. If I've got a first iteration of what I put, and it was so clinical. It's biopsychosocial factors influence pelvic pain. It's that's so boring. Use patient consumer language.
Yes.
That's where the gold is. And they they've got great metaphors to describe their pain, dialing up your pain.
Yes.
And those that's where the gold is. So using consumer and patient language, so important.
We used your stuff, Millie.
Yeah, we did.
Thank you.
We did credit you though.
We did credit you. Yes, absolutely.
We had your name written on
it. That's okay.
Yeah, we did.
Okay. So what I was thinking about is that pain education is so important, but it's so important as practitioners that we get it right and think very carefully about the language that we're using, because it can easily go wrong. And one story that Cherie and I have talked about a few times is we had a young lady who we were looking after who came to us, interestingly, to one of these workshops, who had been told, after struggling like you had, but longer, that the pain was in her brain and she needed to change her brain. And that was the advice.
She needed to fix her brain.
Yeah, I remember change, but that doesn't probably...
No, well, I think we had a couple of conversations because I think we were just so stunned at what this person had been told.
Oh, that's horrific.
Yeah.
Yes. But if you think about Lorimer Moseley's teaching, you can see where that statement came from, and it probably was meant to be helpful, but that was just, it sent her into such a spin because, this was someone who was trying to get better but didn't know how to digest or what to do with that information.
Telling her she needs neurosurgery.
Yeah, she needed to change her brain.
And I think we need to preface it with that we don't have the full context. Yes. But the important point was that whoever this practitioner was, I'm sure they were, had good intentions, but it was just that between the information provided and the understanding of that information, something's kind of wires have got crossed.
She's taken away from it.
That might not have even.
But that's probably wasn't the intention. Absolutely not the intention
or
at all.
Or even the verbalisation.
Or
might
even
have been.
of it. But it's just that's the message that has been kind of understood.
Yeah.
So, and I was reading through some of your other work that some of your other studies that you've done have been trying to filter through with a bunch of clinicians who work in the area, experts around what might be some important messages.
Yeah.
I just wonder if you could share a bit about what you learned through that study.
Yeah, for sure. So we did a Delphi, which is basically a fancy way of saying an iterative rounds of surveys to get consensus on what clinicians think should be the important concepts. And
this reminds me, it probably, again, we're talking about before about how we can sometimes get caught up in like analogies and things, but that just reminds me of like a progressive dinner or something where there's like things get thrown around and then you go to the next house and you pick up. That's probably not quite what happens in a Delphi study, but that's what happens in my brain.
No, that's so fair.
So Delphi study.
So we asked them to generate a bunch of different concepts, be like, what do you think these people should learn and what's most helpful? And in the end, they came up with 125 different concepts, which is just like, that's not helpful to anyone, let's be honest. Like a list of 125 concepts.
What did you do with that?
So we grouped them to try and make them a little bit more digestible. So we put them into 13 overarching concepts. And excitingly, they were actually they were very similar to what the patients and the consumers valued. So learning about the role of the brain and the nervous system and learning how that can become sensitized over time and that many factors influence pelvic pain, including our biological factors, including our psychological well-being and our social well-being as well. And learning that, pain can change and get better and that pain education can be really helpful as well. So yeah, that was really nice actually to come away finishing my PhD being like, okay, cool. It seems like clinicians and these patients who had engaged in education are valuing the same things. So that really provides us a nice framework to be able to go, okay, I think we're on the right track. Like we've got a good starting point to sort of start implementing and drip feeding these concepts.
Sounds like it would have been
25.
Yeah, I know.
Yeah, it's a lot.
It sounds like it would have been really rewarding and to be involved in true research to practice.
Yes.
With really useful information.
Yeah, for sure. And I'm not a clinician. I always disclose that. So, and I'm very much aware of that.
Which is probably a good thing because you're not coming at it from a clinician perspective. Like you've got this really objective viewpoint.
Yeah, I definitely, when I started my PhD, I definitely came in with the patient lens, which, I think can be helpful in some scenarios as well. Creating these concepts. And I think probably what the difference was the emphasis on the tissue pathology side of things. So patients very much said, validation of pathology is important. And I agree, like these people have been experiencing pain for decades, some of them. And so getting validation through a diagnosis is really powerful and helpful for these people as well. So, I always like to find a happy middle ground and a nice balance that it's not either or. It's all tissue damage or it's not tissue damage. It's a puzzle.
Yes.
It's complex. It's got lots of pieces and everyone has their own different pieces. And so being able to figure out what your pelvic pain puzzle is, that's up to you and your healthcare professionals and your and your scenario as well.
Yeah, because you've also done some research around looking at probably way more things that we can cover in the rest of the time that we've got in this podcast, but looking at the guidelines and whether how well they incorporated different types of management. I don't know if you can talk a little bit about some of the take homes from some of those studies.
Yeah, so we did a review of international guidelines for pelvic pain conditions, and so number one was we appraised the quality of them, so how well they were developed. We didn't look at the content specifically in terms of how good the content was, but how they were developed. And then we looked at how frequent different interventions are recommended for the management of pelvic pain. And so for the quality, we found overall they're shit. Like, they were really bad. They don't even describe how they were made. Like
the guidelines themselves.
Yeah, they had 2 sentences and they were so bad. That's why they got rated 1 and 2 out of 7.
Oh, well done.
Yes.
You flunked them.
Yeah, exactly. So the quality of how guidelines are made drastically need to improve. And also with the treatment recommendations, we found by far that biomedical interventions are recommended the most frequently, so medications and surgery, and psychological therapies were recommended. They're probably a bit more common or a bit more frequent than I first thought coming into this. I was thinking, no, they're not going to recommend psychology. They acknowledged it, but they didn't really give specific recommendations. So they were more just a throwaway sentence of, look after your psychosocial well-being. Okay, what does that look like? Yeah. Not helpful.
Yeah.
And other conservative interventions like physio, exercise, all that sort of stuff, that they were recommended hardly at all. Especially in the endo guidelines, there were no conservative interventions were recommended. And that's predominantly due to, I guess, the focus of the research. Like, lots of the research out there has focused on medications and surgery. So they've got evidence out there for those. For things like pelvic floor physio, classic example, we don't really have much evidence out there about what that looks like, especially in the endo space. Anecdotally, we know it can be really helpful and for other pelvic pain conditions, but we just don't have that high quality evidence yet.
Yes, that's right. I love your use of the word yet.
Yet, yes.
But yeah, I mean, we love some lifestyle medicine, which involves food, movement, sleep, stress, social connection. I do sun too. And I often think, well, I mean, and we work in an evidence-based practice, but if no one's out there funding some of this stuff, how are we going to get the evidence? That's the tricky bit, isn't it?
I think it's not sexy.
It's not sexy.
Yes. Nothing about what you write.
But yeah, I know, but it's so. But it's just kind of, for me, the way that I think about it is you've just talked about brain science, like, the brain and nervous system involvement in pain science, and we've talked about the the biomedical or biological factors and the psychosocial factors. So for me, it makes sense, and with my training, I'm able to do that. Is like, well, we address. There's that mind-body connection, but somehow we're still, not acknowledging that.
It's very much treated as as separate
entities
and I think it's like we need to stop saying humans are machines and you need to go to the mechanic to fix you. Like, we're so much more complex than that. Like, our systems are all working together with our environment that makes us experience what we experience. And it's not just pain. It's things like joy and pleasure. It works in the exact same way. So, yeah, I think some of the metaphors that we use as well probably aren't super helpful either.
Yes, perhaps in some of that blokey kind of fields that you were talking about, there's often talking about cars and getting your service and all of that sort of stuff. Yeah, it probably doesn't always apply that well. So, Millie, we're just about out of time.
No, it's such a shame.
I know.
I feel like we were just at the tip of the iceberg.
I told you I could talk.
But we're just so interested in your work and what you do.
Yes, we must get you back.
I think so.
Yeah, so much more to unpack. But I guess now you're a postdoctoral researcher. You're a scientist. I've seen you present at different places. You have been involved in so much work already. I wonder if you could look back as the scientist that you are, back to the little girl that you were, back and forth in the car to and from Port Augusta, and are there any sort of reflections or what you would say to that kid now about their pain journey?
Yeah, I think advocation is a big thing, advocating for you and your circumstances. being grateful for the people around you, knowing that you have a really good family and a really good support system, and just knowing that, life unfortunately throws these awful curveballs, and when you're in the trenches of them, it can seem like there's no way out and things are just going to stay awful and you're never going to really achieve anything. But with the right people for you and your circumstances, things can change and get better. And so, having my second surgery, that was at the end of year 12, and then going into uni, I'm so grateful that it didn't take me 10 years to get a diagnosis and feel believed and know that actually, what you're experiencing isn't normal and you don't have to put up with this. I think that also plays such a large role, and just focusing on what works for me, because just because I said I did all of this sort of stuff if there was a person sitting next to me, it probably doesn't work for them. They've got to find out what works for them. But taking that holistic view, looking wide beyond not just what's going on in your body, but just checking in, how are you going mentally, what are other external life factors, I think, and being proud of, being able to do that at quite a young age. And I'm not taking all the credit for that as well. I think I've talked about a lot, but good support system, whether that's family, whether that's friends, partners.
Big shout out to mum. You mentioned mum a few things.
Go mum. Mum.
Well done, Mrs. Mum. Yeah, Mrs. Mardon. Mum Mardon.
But I think that's really important. And just knowing that, it's not all doom and gloom forever and things can get better and you can live the life that you want to, pending few hiccups. But I think that's just life.
Millie, so lovely to have a good chat with you today. Can't wait to get you back on the podcast and unravel some more of the work that you're doing, including your new trial coming up on medical marijuana use, which we haven't managed to cover, but we'll get you back and talk more about that.
Yeah. When the trial has progressed a little bit more, maybe that'll be a good time.
Love to, yeah. Millie, thank you so much for coming on the podcast, and for those listening, we'll see you next time.
Thanks so much.